Okay, all. It's nice to see everyone. I think we'll go ahead and get started so that our speakers have the full time. And so I will introduce the talk. Again, I'm Mari Yamamoto. I'm one of the Grand Rounds committee members. Thank you so much for joining us today for our, first Grand Rounds of this 2025. So we will be And our speakers are Daniel McDuff and Matthew Thompson. Their bios. So Daniel McDuff is a staff research scientist and manager at Google and affiliate faculty at the University of Washington. Daniel completed his PhD at the MIT Media Lab in 2014 and has a BA and master's from Cambridge University. Daniel has published over 200 peer-reviewed papers on AI and machine learning, human-computer interaction, medicine, and biomedical engineering. Daniel's work has been reported in many publications, including The Times, The New York Times, The Wall Street Journal, BBC News, New Scientist, Scientific American, and Forbes. And Dr. Matthew Thompson is a professor within our department. So is a family physician, professor of family medicine at the UW Department of Family Medicine. He has spent his career in the US and UK combining clinical practice with research in a number of high priority topics in primary care. He also has a strong interest in identifying new technologies that can enhance primary care. Over the last 2 years, he has been working at Google in Seattle, where he is responsible for a number of clinical research studies in the US and overseas. Part of his work at Google involves exploring the use of generative AI in healthcare. So thank you both for being here.
Thanks for the introduction. As Mari said, I'm Daniel. I'm going to be talking in the first half of this presentation about AI. It's going to be a kind of whistle-stop tour, so there's many things I couldn't include here. Happy to take questions during the talk as well as afterwards. Just to start off with, Matthew and I are both employees of Google, so we own stock. This is part of our normal compensation. So I'm going to just run through kind of the development of AI and some of the key properties and just show a few examples before Matthew talks about applications in primary care. So AI is sort of commonly regarded to kind of be founded in the 40s. That work of Alan Turing kind of inspired the idea that machines can think or can do tasks that involve numerical kind of computation, and that you can design tests to compare those to human intelligence. The Dartmouth research project is one of the sort of key markers where the term artificial intelligence was actually coined. And then in the 1980s is when the kind of the current form of models that are known as neural networks were first really developed and scaled. And a lot of this progress, is quite slow. 50 years here between the 1940s and 1990s. But it really was because compute was not up to the sort of scale or performance that was necessary to design really capable systems. But supercomputing systems like Deep Blue, which could play chess, were also kind of landmark parts of the progress. And then towards the end of the noughties, deep learning was developed. And this is a term you've probably heard of. Deep learning is just a form of machine learning that involves large parameter networks with many layers, which can capture many different representations of data. Then about a decade later, transformers, which I'm going to talk about a lot, were created. And transformers are really the sort of universally used form of machine learning model right now for state-of-the-art AI systems. Gen AI has become very popular over the last few years, and this is the idea that you can train machine learning models to be generative, so not just classify things, but also generate language, generate videos, images, and that has really created a shift in terms of how people think about the ways of using these systems and also training them. There's a lot of talk about AI in the popular press, I just want to highlight a couple of key terms. So you might have heard of artificial general intelligence. That's the idea that a machine learning model can be generalized and can do many different tasks. That has been achieved in narrow application, sort of narrow domains, but not there's no sort of real general intelligence yet. And then super intelligence is something that you might have heard a term also heard used, and that's still a long way off. So this is far exceeding human performance on many tasks. But in narrow domains, machines can obviously beat humans at different tasks, including playing chess or playing Go or solving different types of problems, recalling information, etc. So there's definitely a lot of progress that's been made, but AI is still relatively narrow in what it can do. There's just a glossary here, a few terms that I'll use. Pre-training is a form of teaching models that involves very simple pretext tasks. So not using a lot of labels, but using just data that is found mostly from the internet or from other available public data sources. Supervised training is where we use labels, which are often generated by humans, by experts in different forms. And that's the model is often fine-tuned using that information. Neural networks, as I mentioned, are the commonly used model architecture, and transformers are the specific variant that is used for the GPTs, the Geminis, all of those types of models that you might use. Tokens are the machine's representation of data. So machines can't understand language like we do. It has to be converted into numbers first. And so when I talk about tokens, that's the numerical representation of any data that it sees. And then attention is a specific term related to transformers where a machine is taught to pay attention to specific parts of the data during training. And you'll hear this term a lot as well. Really, the main takeaways in AI and the development over the past 10 years can be simplified as creating simpler training paradigms where the training objectives are actually quite straightforward. And I'll give examples of those in a minute. And that allows you to create larger models with larger data sets because those simple training objectives can be scaled. So you can be computed very fast, and so you can train on lots and lots of data. And while, yes, these models are often trained on vast amounts of data, often pulled from the internet and other places, there is a focus still on creating high quality data sources, particularly for that fine-tuning stage. Because it's well regarded that the final performance of the model is really dependent on the quality of your data for a particular task. Obviously, in medicine, that's really important. Model sizes have been growing exponentially. So this is just an idea. This is a log scale here. This is the number of parameters that these models have. And UW was actually one of the universities that really kind of popularized this idea of large scale, large parameter models, particularly in language. Then, since then, these have been exploited and grown often by companies who can afford to train the models. These are quite expensive models to train because they involve a lot of compute, a lot of data. So the ones that you see here, I was involved in the Bloom project, which is the only one of these really that's an open, sort of a public initiative, but it was funded by NVIDIA. But Llama comes from Meta, Palm is Google, GPT is OpenAI. So really to create these large models requires a lot of resources, and so that's why. The models scale really interestingly quite linearly with three main sets of resources. Compute, so the amount of operations your computer or your data center can use. the data set size, which is the number of, often quantified as the number of tokens that you give the model during training, and then the number of parameters of that model. And these scaling laws are something that have really inspired that growth that you saw on the previous slide. So in order to sort of justify a 10x investment in building a bigger model, you kind of need to be able to anticipate that you're going to get some return on that training investment. And so you can see that these scaling laws, they're linear in this log space, but not linear they're not both kind of linear in compute and linear in test loss. So in medicine, we've seen performance of these models increase very similarly, kind of as the models get larger, as they're trained with more data. And this performance here is on USMLE questions. I want to preface that many of these benchmarks are not necessarily what you would want your system to do in the final version, right? We're not trying to train computers that can just answer qualifying exams in medicine, right? We're trying to train systems that are useful to humans. But this is one of the benchmarks that's easy to sort of quantify, and we have publicly available data. So that's been used a lot. And as you can see, over the past 5 years, these have improved dramatically in performance, from 33% accuracy up to above 90%. So way above what, again, a human might achieve, but I want to say it's a bit of artificial. I want to emphasize that we're not really claiming that this could be a doctor, right? It's just a benchmark for analyzing that hill climbing task of how much better is it getting on these questions. To give you an idea of scale, just like one of the data points here, so the PubMed GPT, this is trained on about 50 billion tokens, 16 million abstracts from PubMed articles. So it gives you kind of an idea of the scale. You might hear in the popular press discussions about the fact that we're kind of running out of training data because these systems are trained on everything on the internet. I don't really think that's the case, because there's lots of other data that's not just text data that's in the world, of course. But that is a conversation you might hear. I also want to point out that accuracy on these types of tasks doesn't reflect necessarily utility. So it's important that we think about, okay, what are these systems going to be used for? It might be that an entirely functional and useful system only needs to attain kind of 60% on this benchmark. But that's something where really we need to kind of bridge disciplines and understand, okay, how are these models going to be used? I'm going to focus on language, but many of the things I talk about apply to multimodal data, so images, which are obviously very common in medicine as well. But in language, what these models do is learn relationships between words in sentences, this attention that I mentioned before. The model is learning that this word is associated with this word, is associated with this word during training. So it learns to kind of focus on relationships between words in sentences. And this is the paper that proposed the transformer architecture, is really a milestone kind of in the development of these large Gen AI models. I won't talk about the kind of network architecture too much, but really want to emphasize that these architectures are actually quite simple and can be used for many different types of data. So there's been this sort of homogenization across AI. When I started my PhD in 2009, there was people studying language over here, people studying vision here, people studying audio over here, and they're all using different types of models, different data sets. But now everyone uses the same architectures because of the efficiency to train them and how performant they are. That's not necessarily a good thing, right? It might be that we're focusing on a local minima, but it is helpful because it allows you to build these multimodal systems, which are where a lot of the exciting applications are. So that the training objective for these models, as I mentioned, is very, very simple. Often you just provide a sentence and hide some of the words. Sometimes it's in the middle of the sentence, sometimes it's the end of the sentence, and you ask the model to predict what words were missing. And then you give it some penalty or reward for getting it right or wrong. And these pretext tasks, although they're very, very simple, lead to quite complex abilities. So you can train a model using this simple set of gap-filling tasks. And then that model can be used to summarize whole documents. So it's quite remarkable how using relatively trivial training objectives, you can create models that can do quite interesting, higher level, what you might think of as like higher level, complex cognitive tasks, like summarizing documents, extracting information, answering questions. And that's, again, been one of the real fundamental shifts in AI, is that these models aren't really trained with those objectives to start with, but there's what people call emergent capabilities. And so then we can create models that can combine information from different modalities, images, text, audio. And this is what a foundation model is. So a foundation model is designed to intake relatively raw data, as raw as you can encode it, ideally, and then can generalize to many different types of tasks, whether it's like answering questions about that data, summarizing it, forecasting it, classifying it, translating it, retrieving information, things like that. And these foundation models can be fine-tuned for things to improve their abilities on X, Y, and Z, but the fact that they are so versatile is what really makes it easy to build new types of applications. So here's an example of MedGemini, which is a medically tuned Gemini model from Google. I'm sorry, it's a little hard to read here on the projector, but we can share our slides. And this example is in a publication, the MedGemini paper. But what you can see here is the ability for the model to maintain dialogue. So that's like one linguistic skill. It can answer questions and do that in a way that is sort of natural dialogue. It can retrieve relatively complex information and synthesize that. And it can also take in images as well. So it's like doing all of these tasks, this just simple kind of 4 to 5 turn interaction is showing examples of all those different capabilities that the model can do. And you may well have experimented with these systems, but that's just, yeah, to kind of give an idea of how they're created. I want to give one example of some results and one additional application of these models before I pass over to Matthew. So the example of performance I want to look at is differential diagnosis. So in order to validate these systems, we want kind of benchmark tasks. And for this, we used NEJM case studies. So this is a little bit artificial. Again, I want to recognize that it's not like, this is not necessarily what you would ask a human to do. But these case studies present quite a nice controlled set of data where we can test the model's ability to derive a differential based on some case presentation that is given. And so in these articles, you have the case presentation, you often have some labs or imaging, then you have an expert differential and a final diagnosis that's determined. So what we did was we hid all of that latter stuff from the model. We just provided it with the history and the labs and the images. And then we asked it to generate the differential and also generate a final diagnosis. And then we had human clinicians do this task without aid of the LLM, and then do it with aid of the LLM, the language model. And we also had a control condition where they had access to search. So they had access to Google search, but they didn't have access to the language model, because that's kind of what we regard as one of the harder baselines to beat. So what you see here is the distribution of answers. So the 5 is the best, that their differential contains the correct diagnosis. 1 is the worst, where there was nothing in the differential list that was relevant. And you can see the performance of the unassisted clinicians here. When they're assisted by search, this performance gets better. But then when assisted by the LLM, it gets even better. And interestingly, even just asking the LLM to do this on its own, it gets even better. I want to emphasize that this is not any critique of clinician skill. This is just highlighting that these models are quite good at pulling out esoteric or specialized information from large bodies of text. And so it's not a fair comparison. The LLM has seen many, many more thousand articles than a human could ever read in their lifetime, or would read in their lifetime. And also, there may be some presence of these articles even in the training set. So this is an upper bound. But what's most interesting to us is that clinicians assisted by the LLM improve substantially over those that didn't have access to it. So it's suggesting that, yeah, these models actually have utility in helping people find information in these relatively unstructured tasks. Finally, I want to talk briefly about agents. So there's LLMs, and you would probably have interacted with GPT or Gemini, whether it's via search or just via the direct interface. But now people are moving on to create agentic systems, which are systems involving multiple models. And the reason for this is you can prompt these models to be experts in different domains. You can fine-tune them to get better performance. And then they can work together to exceed the ability of a single model on its own. And so this is something that we're exploring is how do you organize these agents? So here, these people represent LLMs with different capabilities or different specialties. But then how do you have them work together to solve from more simple to more complex reasoning tasks about medical data? And here, we just used inspiration, an analogy from how humans work together to inspire the design of these systems. It's not mimicking how healthcare works, but it's just an inspiration to figure out how do we get these language models to talk to each other? So here's an example. You have a question and an image, and you're asking, what does the image represent or demonstrate? And then the system classifies that task into a level of low, moderate, or high complexity, decides on how to recruit multiple models with different specialties. And then those models have a conversation together. So they discuss. So model 1 here is coming up with one assessment, model 3 and 4 a different one. And so then they have a discussion, they have a back and forth. So they have multiple rounds of discussion or interaction, and then come up with a final decision. And what's really interesting is even if each of these agents is based on the same base model, they're all Gemini models, but they're just prompted or tuned slightly differently. When they do this sort of deliberation process, they get to better performance. So on these types of clinical reasoning benchmarks, single agents, which is just a single LLM, perform less well than an adaptive system, which has this sort of discussion process prior to making the final or generating the final answer. And you'll see a lot more of these agentic systems where particular models are tuned to do specific things, because as I mentioned right at the beginning of the presentation, we don't have general intelligence yet. We don't have super intelligence. We can design models to do specific things really, really well, but then they need to work together. You need to put them together like a jigsaw to get to your final system, which might be something that generates a diagnosis or assists a clinician in retrieving information from medical text or something else. So now I'm going to pass over to Matthew, yeah, happy to take questions on that at the end. I appreciate this whistle-stop tour of AI and many things I couldn't cover, but thank you for your attention.
Thanks, Daniel. I always learn more and more every time I hear one of our software engineers and computing experts talk. So that was fantastic. So what about primary care? The other way. What about primary care? Well, you've probably seen in the press, in our kind of medical press and lay press, just endless editorials, commentaries about AI and how it's going to change, and it's not just the States, it's global. And exactly the same conversations and excitement in Europe when I've been there in Britain. Even our own Dr. Frogner, writing in the Seattle Times, I think a week ago, was highlighting, could AI help with some of the things that she as a patient is facing, medical bills and finding a provider? So it's really filtered throughout our world. And I thought I'd focus on a few pain points that I experience in clinical practice. These aren't all of the pain points, but these are some of the ones that I've come across and I've thought about and looked at the literature to see, well, maybe is AI going to help us? And if not now, when? So the first one is chronic disease management, which seems to occupy a huge amount of our clinical days currently in primary care. So how good is AI at helping with chronic disease management? Well, let's turn to randomized controlled trials, which I think we'd probably agree is the best way to tell if something truly works or not. And this was a recent systematic review. And you'll see almost all of the literature we talk about is this year, last year. It's very, very recent. And if you look at all of the randomized controlled trials done in the world, look at the specialties: gastroenterology, radiology, cardiology, surgery, and there's little primary care at the end. Very, very little evidence of randomized trials. And these were randomized trials of AI in clinical practice. So clinical practice which used AI. Almost no trials done in primary care. Even the trials that they have done, typically single-center trials, maybe not well done or well reported. So the randomized controlled trial evidence of chronic disease management is not great. In fact, I'd argue it's very poor. How about chatbots? Wouldn't it be amazing if our patients with diabetes or hypertension could engage with a chatbot and take away some of this, I don't know about your epic inbox, but people with, here's my blood pressure this week, doctor, and like, okay, should I increase my lisinopril or decrease this? We get this a lot. Would a chatbot help? Well, there has been a bunch of trials where they've randomized people to chatbots versus usual care. Again, this is a publication last year. Yeah, look at the topic areas: hypertension, diabetes, chronic pain. Fairly meager amount of evidence. And I just picked out two of the trials that had been done in primary care. And none of the details are small. But the top one was a trial of people with hypertension in Spain. They randomized people to a chatbot to give them information about hypertension versus usual care. And sure enough, the people in the chatbot had more information, maybe better adherence, which is great. Not particularly insightful in terms of better hypertensive outcomes, but at least it's something. The bottom one was a trial in Australia of people with type 2 diabetes, where they randomized them to a chatbot, they would upload their blood glucose levels, and it would give them some advice compared to control. And sure, at the end of a year, the people in the chatbots had better quality of life, but the A1C was exactly the same. So not really particularly convincing so far. So I'd say chronic disease management, a lot more to be done. I don't think we'd feel comfortable right now with implementing these systems without much more research evidence of effectiveness and safety. Second one is documentation. And this is very timely. I think there was an email just a couple of hours ago about the potential rollout of the ambient AI recording system at UW Medicine. And this kind of pajama time, and I had no idea that pajama time was an actual storybook and songs about pajama time. My kids are so old now. But pajama time and working outside clinic has been a bugbear for years and years and years. And I think it's one of the things that contributes to our burnout and misery with with working with not just Epic, but any medical record system. And yet there's a bunch of companies, and none of these are Google, a bunch of companies who are making ambient office voice recording systems. So what evidence do you think we need before we start implementing it? It was interesting. Kaiser, don't know if you've got any friends that work at Kaiser. Kaiser implemented this throughout all of their clinics last year. And they didn't, I think they did this not because they had great evidence it was going to work, but because the demand from the clinicians is so high to try and do something about this miserable, time we spend on Epic. They use Epic as well. And when we look at the literature, there's been a few studies of ambient or AI-powered clinical documentation. This was a non-randomized trial from Atrium Health, and they recruited family doctors, internists, pediatricians, so kind of similar to our type of setting. They had 85 the clinicians, included doctors and advanced practitioners, did 1 hour training with Dragon DAX. Then they had a comparison group. The respondents, I think you'd agree they're similar to us, 50, mostly female, fairly experienced in terms of years of practice. It didn't tell us how long they actually used the system for, but, and then they gave them a survey before and after they implemented their Dragon DAX. So what did they find? So intervention, decreased time on EHR at home, 47%, pretty good. Decreased weekly time on EHR, 44%. Decreased time and documentation after the visit, 43%. Those seem quite good, but if you look at the control group, like 20% of people where they did nothing seem to have less pajama time. That doesn't really make sense to me. Like just by doing nothing, you've got 20% less pajama time coding. It doesn't really make sense. And is this a good news or a bad news story? I think this is like how much decreased pajama time is good enough. How much would decrease our burnout? How much would give us more time in that 10, 15, 20-minute consultation? What is good enough? I think maybe the saddest thing at the bottom in terms of EHR experiences comparable before and after the intervention, well, wasn't that different. Well, it's not really that different. In other words, whatever we did, people were about the same. So even if we did implement Dragon DAX, would it really change things that much? There's been some other studies looking at impact of this kind of system on burnout, and I think it's variable effects. Some studies finding a reduced documentation and finding change in burnout, others not finding change in burnout. And it could be that this, even though we complain about it, I complain about it, maybe this is not the only thing contributing to burnout. So it's not a magic bullet, far from it. And the third is, and this is an area I've been really excited about, and hearing Daniel's talk again, I think this is where we could find some quite exciting results, diagnostic decision-making. And it's, Daniel's published on this, and there's been some other studies. This was another, I'd say, fairly good trial in JAMA, which compared the performance of physicians using GPT in addition to conventional resources. So this was, they gave clinicians 6 vignettes, they gave them an hour to look at them, and they looked at their performance in terms of an overall kind of diagnostic score. So if you look at the results here, you see that physicians who used LLM got things right about 76% of the time, let's say. Physicians using conventional resources like UpToDate or whatever, about 74%. So no difference there. But then when they just ran the LLM on its own, it actually did better than the physicians. And this again echoes what Daniel was saying earlier. So as the headline, doctors using a chatbot you might as well just use UpToDate, or it's a headline, LLMs are outperforming doctors. You can kind of pick your headline here for the New York Times. But I think this illustrates some of the issues. Another, in fact, negative study, this was using this large publicly accessible database called Mimic, which I think is from intensive care from Harvard or somewhere, where they had just 4 conditions: appendicitis, diverticulitis, pancreatitis, cholecystitis. So this was real patient data. and they compared the performance of doctors in green with different large language models. And I think these are probably older models. I love how they call them wizards, clinical camel, there's always llama, there's always these fun names. And in for these conditions, the doctors did better than the large language models, which is a little bit stunning when you think there's just 4 conditions here. This is probably a ton of data if people are in the ICU, and the doctors are doing better for diagnosing these 4 conditions than the models. So it's interesting. I'd say the reasons I'm skeptical is that most of this research is using these very artificial kinds of data. So the perfectly curated New England Journal types of cases where all the information is there and perfect. It's often very orderly and set out very nicely. It's often in situations where the probability of bad disease is much, much, much higher than what we see, much higher. And often, as Daniel pointed out, there's this multiple choice question, like our board exam questions or our recertification questions, which personally I think are a bit useless. You know, pick from the following 4, like, I don't know. That's not how we work. Not really representative, and almost never including the social determinants of health type of elements that we think about a lot. On the other hand, this is how, on the right, how I think we think. It's diagnostic reasoning is iterative, it's over time, it's very circuitous, often very, very messy. There's often no one diagnosis. We're much more often ruling things out than ruling things in. We're thinking about how to use resources, imaging labs, referrals judiciously, because we can't refer everybody to everything all the time. And continually balancing this new problem, new symptoms, versus everything else going on in the patient's life. So it's this complicated balance. And I think the authors, like Daniel mentioned, I think they would acknowledge this. And I don't think this is rocket science to think that what we do in primary care is somewhat different to the multiple choice type of scenarios. But the reasons I'm optimistic, and I've been at Google for the last couple of years, I'm seeing behind the scenes of what the capabilities are emerging for some of these large language models. So the reasons I'm quite optimistic is that we are already using decision aids. Think about ECGs when it prints out. For how many years has it printed out that little summary at the top? In the old days, it used to say the same thing for all of them. ST, non-specific elevation, like, not again. But we've been using some sort of intelligence to help us for decades, probably decades. Prescribing things, those have been around for decades. I mean, long gone are the days where we carry those little books with the dosing. I mean, you probably, me and you probably have them. But long gone are those days that we rely on online resources. Our patients absolutely rely on internet and online resources far more than information we give them in paper or email. Keeping up to date the old way seems utterly impossible. It just seems utterly impossible. We do make diagnostic errors. I've studied this. We see it in our clinics. We've seen our patients and colleagues experience this. And I think lastly, there's many signals, even in our EHR, that we are not able to see and visualize and appreciate as human doctors. And this is maybe where AI could help us. For example, this is data from Kaiser, and these are the only 2 slides which have got any of my publications. So this was work we did looking at weight loss. So every time a patient comes into any of our clinics, we weigh them. But I would argue that unless someone is gaining a huge amount or losing a ton of weight, or we have them on Ozempic or something, are we really focusing on a 1% change in weight? Absolutely not. I don't think we'd even notice it. Yet, at a large level, your hazard ratio, your risk of getting cancer, even with a 1% weight loss, is there. Of course, at a 10%, it's much higher. Now, and the cancers where it's being missed, it's occurring: pancreas, myeloma, colorectal, gastroesophageal. These are not cancers apart from colorectal that we can screen for. So I would argue something as simple as the number of pounds being measured every visit, we're not seeing, but it's quantifiable data there. Not very sophisticated for software engineers, but for us as a human, we almost always are going to ignore it. And I've seen exactly this in a couple of patients here who we've diagnosed with cancer. The weight was decreasing months before we referred them and diagnosed them. So it's not completely abstract, but this is large scale data. Another thing, and this was using, in fact, this was publication involved probably some people on the call here, and this was using some of the, I think, transformers or BERT models for extracting symptoms from our data. This was a case control study of 600 people at UW who were diagnosed with lung cancer, who'd come through some of our clinics, and 6,000 controls. And if you look at the time of diagnosis, the symptoms, fairly obvious: finger clubbing, lymph nodes, cough, hemoptysis, chest crackles or wheeze. These are all being extracted from what we are typing into Epic, as well as what we're coding. And the complicated AI systems were extracting the words from the history presenting a plate that we were typing. But if you look back a month, 3 months, 6 months, maybe even 12 months, there's evidence of these symptoms building up in these patients. And again, I'd argue it's almost impossible to spot this with our own eyes, given the noise of Epic, the noise of patient care. But this kind of gives me hope that there's some signals there for these bad things. And I'm picking cancer, but you could pick eating disorder, you could pick suicidality, you could pick whatever you want. There's some missing signals there that probably only AI can help us with, and our human brains are just not quite able to appreciate. So what's the way forward? I think number one, it would be great if all of our big companies and technology innovators ask primary care what you want, what we want. I've not really seen a whole bunch of that, to be honest. I've got a slight worry this is going to be a top-down, here's what you're getting. And we, primary care, won't have enough input into what we really want. There have been some attempts to ask primary care doctors. There was a good survey in Canada asking what Canadian GPs would like in terms of AI. And you could see here, we'd probably share some of these, like admin support, patient self-management, better communication to help, back and forth with the medical record system. And many of these are focused on some of the urgent things which are causing burnout, like documentation, and those administrative hassles. In fact, and many of these shared priorities are, again, the same across the world. There's nothing particularly bad or unique about American healthcare, where GPs around the world suffer from these exact same problems. So it's not just an American problem. There's almost nothing asked about our primary care teams. So what would our front desk people prioritize? What would our MAs? What would our lab? What would our between visit care people prioritize? I don't think anybody asked those. So that seems like a ripe area to figure out what's needed. And not just needed, what are the barriers? What are the barriers? There's a great study of UK general practitioners about AI and the future of primary care. And I think you'd probably agree with many of these. Please hurry up with the technology advances to take away some of the crap that I still have to deal with. We're essentially a people business. It's personal relationships that count. So this kind of balance of take away some of the crap and let me do the patient-facing human stuff, that comes across loud and clear. And I'm sure if we repeated this kind of survey here, we'd come up with something similar in terms of, let me focus on the things that AI probably can't do quite well, which is the human-to-human interaction, listening, empathy, all these other things, but take away the crap that is kind of destroying the profession and our lives and our pajama time. The second is generating research. I think we're in a real problem here where AI is advancing so much faster than our ability to generate research. I've not seen, and I'm not applying for grants, as Andrea's probably happy about, I've not seen a vast amount of research grants for implementation of AI in primary care. maybe others have, but we've got this massive mismatch between the billions going into research and development and very, very little going into implementation science research. That really worries me. That really worries me. And it's clear, thinking about, should Kaiser have implemented their ambient office thing, wouldn't say without any research? Is that good? And kind of put up with, well, it's not going to be perfect, but it's better than nothing. Or is the UW medicine approach good? And looking at the email from this morning, it looks like it's going to be a quite controlled, almost randomized, staged approach. Let's generate evidence, see if it works, see if it doesn't work. Which is best? Do you need a randomized control trial, or do you just need to get something out and make some changes to the things that are burning us out and driving us away from practice? I don't have the answer to that. The number of randomized control trials I told you earlier is shocking in a way if we think we're going to be using AI routinely, because we'll need a heck of a lot more evidence before most of us are going to be happy to say, all right, take my diabetic patient and the chatbot is good for them. We're going to need a heck of a lot more data before we get happy with that, I think. And this is just an example of how quickly the FDA is authorizing a bunch of AI devices. I don't think generative AI, I think this is just regular AI. I think the FDA is still struggling with generative AI tools. But look at AI, it's gone from almost nothing to hundreds of AI tools, devices being approved. And that's putting aside digital health tools, where over 300,000 digital health tools. So that the world here of digital tools and AI is expanding quickly. How about education? I gave a talk last year to the first year medical students for their research methods course. And I asked, hands up, who's had any training in AI? Not one student put their hand up. So there's something missing with our students, residents, practice staff about AI training. If this thing is really happening, how are we going to train people to use it? And there are some competencies that have already been proposed, which seem pretty good. You know, educating our residents about what is it, should I use it, when should I use it, how do I use it, et cetera, et cetera. So I think we could, for the educators here, we could probably do a whole bunch more in terms of how we're educating our students, PAs, residents. And lastly, I would argue, unless we have partnerships that are public, private, local, national, specialty, clinic, et cetera, unless we have partnerships and co-design things aren't going to work out too well. Think about medical record systems that we've lived through. They came and we spent years and years and years kind of trying to make them better and struggling and complaining and whining about it. It really wasn't co-designed. It was given to us and thrust upon us. And then it's taken many, many years for us, primary care clinicians, nurses, PCPs, to have some influence in changing it. I really worry that even though it should be a multidisciplinary stakeholder thing, it won't be, and primary care will be the recipient of rather than a true contributor to. So that's a question. We've got a good 10 minutes for questions and answers. Thanks for listening. And I would say overall, I'm excited by what I'm seeing, but I'm cautiously excited. I think, like many of you, I've been through these other revolutions in healthcare that were going to change our lives, like mapping the human genome, or things which were going to revolutionize. And they've not really quite filtered down in the ways that we were expecting. So I hope this is not going to be that same, a lot of hype, but not much that filters down to our day-to-day lives for us and our patients. So anyway, questions for Daniel and I, that would be great. Yeah, question from Carrie, go ahead. Hopefully it's for Daniel and it's something complicated on transformers. That would be great.
You wish, Matthew. Hi, Daniel. Great talk, you guys. This is fantastic. I'm Carrie Stevens, and as Matthew knows, I'm in addition to being a psychologist, an informaticist. And I know Angud's on the call along with some others that are actually working with us on the study that we're doing for the rollout of our AI documentation tool that the solicitation Matthew just got, and a whole bunch of you listening on the call right now. So it's a little plug for please respond to that and participate in that study. I think that, you know, the blend of how we can partner not just, you know, research within universities and within health system side operational people, but also with industry on how we can rapid study these kinds of solutions, because I think we all have a critical part to play. You know, we can be part of the data source on the health system side that generates that. And, you know, and the industry partner can be the nimble one to change the product to how it needs to be. And, you know, research minds together on both sides, you know, of university and industry can think together about what to study. My question is, from an industry perspective, because you guys are both here representing Google on some level, how does industry think about potential harm from these products? If we just go with the AI documentation solution as an example, you know, it may be that when our folks are getting their notes taken, they are having a detriment to not remembering what happened with their patients as much as when you repeat something and you have to write it down, may not synthesize information as much. When you have to document it, you have to sort of put it together. At least as a psychologist, I have to do a case conceptualization on some level, put it in there. You know, so there can be detriments to it that are hidden that we don't know about, which I think is part of the value of studying as we go, especially when, you know, we're in progress of rolling it out. We're doing that operationally, it's happening. And our institution's been awesome at partnering. Thank you, Angud and team, to say, okay, let's go ahead and randomize the rollout so we can study this on both sides. So how does industry think about the harm side of it? Because I know, you know, the purpose of business is to make money in capitalism.
I can take a stab at that. So, I mean, half of my work is in the field of human-computer interaction. So, like, I definitely resonate with all the things you're saying. I think studying these systems in situ is really important, and we need cross-disciplinary studies to do that. There are identified issues, things like bias, that we didn't have time to kind of dive into, and also, you know, the way these systems affect people's behavior, and we need to study those, quantify those, and understand the risks. I imagine that in the future, we're maybe not there yet, but this will be much like the conversation with self-driving cars or other things where there's natural apprehension for adopting that, but statistically, it may be a safer solution than having humans do X, Y, or Z. What X, Y, and Z are exactly, that needs to be determined, right? But I think the reality is there are certain things that machines can be trained to do, which you can essentially prove that can exceed human performance. Machines are extremely good at certain types of tasks, but they're also really bad at other tasks. And so finding that kind of meeting point is the important thing.
I think to your point, Daniel, that, you know, the tool, that's how I think of machine learning, you know, and AI solutions is a tool that can help enable humanity in many ways. And we don't just give a tool out to any human. You know, if you take a gun, for instance, you know, some that it's a tool. In and of itself, a gun is not bad. AI is not, you know, scary and bad. It's who's using it and for what purpose, you know, might be an issue, right? So a hammer, take something less volatile. You wouldn't give to a 1-year-old, you know, that could bang themselves. So how do we know when to put those sort of right tools? And I love that you brought up that hesitation, you know, curve of adoption, because that's where equity really comes into play. Where my concern, for example, about AI documentation implementation here is that we're going to go into patient room and say, hey, we would like to do this. Are you okay with it? And we're going to get a lot of folks who are potentially from the most vulnerable populations over choosing it. When I say over, I don't mean that in a bad way. I mean, but choosing more than well-resourced people to not use that kind of tool in their care, right?
I think, Carrie, I'd agree with in many ways. I'd say all of those are measurable. Those are all the different outcomes of, you know, good outcomes, harmful outcomes, certain biases of who does and doesn't take part, both in terms of the doctor participants or provider participants, as with the patient. Those are all measurable. And I totally agree that let's look at the data. We would never start a new drug without pretty darn robust evidence of benefit over harm. Should AI be different to that? Probably not, in my opinion, because we've kind of had our fingers burned with various things which are going to save our specialty over the years, and they've not really done that. So I think the UW Medicine approach is maybe cautious and appropriate. Maybe the
I don't think our
challenge is,
trial is slowing us down any with implementation, Matthew. So I hear the critique that you're making, but I don't think it's actually valid in this case. Not that it's not valid in general. I think your overall point is true. But I want to let everyone else ask questions and just leave you with, I hope that industry comes and partners with universities to do that kind of research work, because you have much deeper pockets to help us do that rapidly than if we have to rely on, the slow moving federal grant dollars. So thanks.
cool. Chris?
Question, Matt. That was a striking slide you showed. That was a striking slide you showed that almost all of the research for AI in clinical trials was on specialties, not primary care. What can the primary care community do in our communications with industry and academia to bump up the primary care proportion of research?
It's a painful topic for many, many decades for many of us. I think the reason many of these trials will start with those specialties is because of image, radiology image, that's just been the open, and then colonoscopy imaging of, I think this image-based stuff has been easier and more, there's way more money, to be honest, in those radiology imaging. I think the downside of primary care is that we are on a lower cost of medicine. And, think about having a human scribe. For years, if you go to the dermatologist, they've got a lovely young person there typing the notes. We almost never have had that in primary care. Why? Because we just don't bill as much. And I think that inherent unfairness of the system, I think it comes down to that. The thing that maybe makes me optimistic is some of the patient-facing or human public-facing tools could, that people are typically, symptoms, worries, concerns, not, interpret this MRI scan from level 5. And I think that kind of entry level into the primary care system is maybe where we could make inroads, just as internet search is used widely by people, coming into primary care offices. But I think it's the imaging and the super clever work that's gone around image interpretation. So yeah, but is NIH going to respond? Is PCORI going to respond? I don't know. I worry not. I worry not. Oh, not fast enough. Sorry, not fast enough. Yes.
Looking at the data comparing like the chatbot with the provider people, then I was hearing you say there wasn't that much of a statistical significance of complexity. But I'm wondering what the economics are.
Yeah.
And how that might potentially, I would imagine, like certainly generating this technology, it's hugely expensive. But once it's marketed, I would imagine that those are not humans. It would be less expensive, and then being able to sort of reallocate the funding that normally for support staff or for addressing salary gaps. Including that economic data with this really interesting.
100%. And going back to Bianca's thing in the Seattle Times earlier, I think her husband not able to find a doctor. Would it be better to have a chatbot doctor to help with your symptoms than no doctor? I think that's the reality of many of our systems now. It's not, can I pick Dr. James or Dr. So-and-so, Dr. So-and-so. It's like, there's no doctors, no appointments for 6 months. Would it be better to have a chatbot than nothing, or to go to urgent care and
But it just let me point out, it makes total sense that imaging, cardiology, that's massive data sets, more viable, whereas I think primary care, it's not necessarily, the data is not as clean. Which is, I think, would be the reason why those are moving forward, while other care is slower to the doctor to be able to design trials.
that is what gives me optimism. The Yeah. Sorry. The question was, to what extent would, even if a chatbot is the same or less effective than a provider, they could be free, kind of running, the background, having to pay a salary and benefits and everybody. Yeah, that should be factored into the equation. Completely agree. Yeah, completely agree with that. I was going to make some other point. We haven't got into the costs of actually running some of these large language models and the costs, electricity and the economic costs of that. But that's a separate point. The point I was going to say, again, measuring doctor performance, provider performance. What if something was that chatbot was taking off those lipid results that my fingers get tired typing the same thing every time, or the dot phrase, your LDL is, yeah. What if that was safely using the language that Matthew uses in my voice, my language, my recommendations for statins? I'd love stuff like that. And could we measure those times, those minutes saved, and say fewer minutes for that? Chatbot is working quite nicely. Now you've got more minutes for this. And we should be able to measure that. Yeah, Aaron.
Utilizing a lot of those tools that they're generating to be able to assess things, would that be something that we can put over a lens over the inbox to filter like messages of patients, and then be able to categorize them on urgency based on the word usage or triage, those types of things, and utilizing AI in that way, which I think would make almost everybody in this room public.
100%. That sounds like this kind of agentic type approach where certain words, certain urgencies, and certain knowledge of that patient's medical record, like chest pain in a 20-year-old versus chest pain in a 70-year-old, even simplistic things like that, that seems much, much more tangible. But again, could we measure that in terms of number of calls, triage, appropriateness of triage, number of minutes saved, number of MAs being happier? I completely agree. So the thing that gives me excitement is that we've got all these problems, many of which are fixable almost right now. We don't in primary care have to be doing MRI interpretation in real time. We have to be doing message triaging, results, I wouldn't, lab interpretation. These seem very low-hanging fruits for the kind of technologies I'm seeing, which are these multimodal voice, video, image, text. What you describe is such an entry-level thing that could be done very straightforwardly based on the technology. But will we do it? Or will we just, keep beating our stuff to work harder? That's the challenge. All right. Thank you. Thanks for listening.
Yeah.
Never beat the staff. Sorry.